Hey, hello everyone. Thank you for joining this webinar on insights on restoration, recovery and remodelling in mental health. My name is Megan Georgia and I'm the Programme Manager for the Equality Network for Forensic Mental Health Services. Today we have a great range of speakers for you, and they will be introduced shortly by Dr. Quazi Haque, who will be chairing the session today. Quazi is Executive Medical Director for Elysium Healthcare and QNFMHS Advisory Group Chair. If anyone has any questions, please use the Q&A function, which is at the bottom of your screen in the taskbar. And if we've not been able to answer your questions today, as I'm sure we're going to have quite a few, please do feel free to raise it on the Knowledge Hub group separately, and there'll be details of that later on for you to be able to look at that. If you have any good practice related to the discussion, again, please do share that on Knowledge Hub. That would be really helpful to all services too. And we'll be recording this webinar, so anyone that you know that would like to view the session that hasn't had an opportunity to look at it today, please do share it with them. It's on our website, and again at the end of the session there'll be a slide with information of all of our webinars that we've run so far, and we hope you find the session useful. So I'll now pass you over to Dr. Quazi Haque.
Thanks, Megan. Hello everyone, welcome to this webinar on restoration, recovery and remodelling in forensic mental health. I am Callum Ross. I'm a forensic psychiatrist and medical director of Elysium Healthcare, and I've been chair of the Forensic Quality Network for the past 6 years. And yes, this webinar should really be seen as a series of resources and discussions from the college in relation to the COVID crisis. And I'm really pleased we've extended the invitation to clinicians from the wider system and also commissioning colleagues. And we really welcome your interest, involvement, and of course expertise. We're using Zoom, I think, for the first time within this set of meetings, so we're still getting used to the technology, so do bear with us if there's any glitches. But what we really want to do, I think, is make sure the Q&A function is available for you, and rather than skirt over a number of issues, we'll try and pick up a couple of questions at the end and get a good discussion going in some depth. Any other issues that we can't resolve today, we'll put on the Knowledge Hub platform. And I would ask you just to kind of get familiar with that platform and sign up. Certainly in terms of, as a medical director, and my clinical directors have been using the platform an awful lot, as have other colleagues, to share practice, operating procedures, but also I think issues coming up from ethics groups and so on. So a really useful resource. And as Megan says, we'll be recording the webinar and putting it onto the college website. We want to do something which is a bit more practice orientated today rather than a set of briefings. And of course, there's so much we could talk about in terms of the current COVID situation. So please use this as a conduit for further discussion and collaboration. And in that spirit, it's worth mentioning that we have another webinar on June the 2nd from the Prison Network, which is looking at the important topic of entry and release from prison. And that's on the 2nd of June at 4 p.m. Feels like we're entering a new phase of COVID-19. We have test and trace starting across the UK, initially in England and Scotland and Northern Ireland. And it seems an important milestone. But also, we seem to be in a general sense of moving from crisis to recovery, but perhaps not quite yet talking about rebuilding. That feels as though this crisis has been going on for quite a long time. And through the Quality Network, we've been tracking issues from members in the Knowledge Hub. And I think there's been a lot evolving in terms of decisions, issues coming from ethical groups and trusts around managing the initial lockdown. And some of those aspects have evolved. And I think that's probably reflected in the fact that the legal guidance has been updated from a version 1 to a version 2 last week. And what we don't want to do necessarily is retrace the early steps of the lockdown, because that's been handled elsewhere. And I'm grateful to colleagues from Devon and Tees and Ask who've done some fantastic webinars around that. And we're going to think really about the here and now and the next phase, the epidemic. And therefore, I'm very grateful to colleagues from the Secure CRG, but also from the advisory group who have really contributed to this webinar. We have past and present members, and they all have good visibility of the mental health system beyond forensic, because we're not trying to be too parochial here, but also I think we want to make sure we've got perspectives from the point of view of clinicians, senior leadership, lived experience and regulation. So if we just go on to the next slide, I'll just introduce our discussants briefly. If we could do that, Megan, that'd be great. Thank you. So Paul Gilluley is a consultant in forensic psychiatry. I feel as if I've known him all my professional life. It's probably not that way, but he's a very experienced forensic psychiatrist, Chief Medical Officer for East London Mental Health Foundation Trust, which is an outstanding trust was rated by the CQC, and a wide range of mental health services, including forensic mental health. And I think you could cut it any way, but really looking after a population with high indices of social deprivation in areas. So very important in terms of this crisis. We also have Dr. Callum Ross, who's a consultant forensic psychiatrist at Broadmoor, and he was originally involved in the DSPD pilots and has retained an interest in personality disorder. But he's here really, I think, to discuss primarily the interface between prisons and forensic mental health, which has been a key area to think about over this period. I'm delighted to have Sheena Foster with us, who's our Friends and Families representative on the advisory board, and she also sits on the Secure CRG, and Sheena has a son in a secure service where they've had confirmed cases of COVID-19. Dr. Sarah Markham is with us, who's a patient reviewer for the Quality Network, I think since 2012, and she's a keen advocate for rights-based approaches and collaborative practices through secure and forensic services. And then last but not least, we have Matt Kinton, who's the National Mental Health Policy Advisor for the CQC since its creation in 2009, and in fact was in the same role for the Commission before that. So I think it's fair to say that Matt has seen a lot of change and has also authored many national reports on the Mental Health Act and is a member of our advisory board. So I'm grateful for them all. They've all been asked, I think, to frame their discussion around a number of core themes, and we'll try and pick that up on the next slide if we could. And I think the points to really say is that we are anticipating repeated cycles of COVID-19 and of course considerable regional and local responses. Services already had to respond, I think, in a very limited time to rapidly evolving guidance and decide what is essential and what is less critical. And of course that's raised issues in terms of restrictive practices and safeguarding and care of service users. We now have legal guidance, which is helpful, but we want to think about how that is maintained and that we have an ethical and legal framework for safeguarding the rights of service users moving forward. We know services have been thinking about environmental design and infection control, whether that's around individuals or the isolation of units, or in fact around cohorting strategies. And at times this is felt, I think, reactive, and it's really about how we prepare for this in the future to create clinical approaches that provide recovery, but also a reasonable quality of life. And then, of course, the other key areas around co-production. I think a genuine concern was the disintegration of co-production as the lockdown started, but certainly we have heard through our membership and seen really some fantastic examples of discussion and involvement between service users and clinicians around handling the changes in terms of social restrictions, dealing with communication and PPE, and many other areas. But today we want to think about how co-production can be used in a positive way and as an opportunity as part of the next stage. But I think a key area for the discussion is also around future models of care. And really, if we go into the next slide as an endpoint, what we want to do is really map out or give some suggestions around how services can take a quality improvement-based approach towards planning for the next phase of care. This is critical as models of care clearly need to be sustainable, evidence-based, and have a rationale. And I'm not going to talk about using phrases such as the new normal, because many of us are still dealing with the here and now. But we need to think about how we bridge that gap and get to a refined and newly defined business as usual. And I don't think that's necessarily just about integrating better infection control across our services. It's how our local forensic systems retain a working together solution that still champions prevention at a time, I think, when there's been huge turbulence in community support and uncertainty around the future resilience of local healthcare systems. Demand is changing, and we're still trying to understand and measure that. There's likely new unmet need, not only through direct transfers into the forensic system, but in terms of wider needs in the groups that have considerable healthcare inequalities that are widening. We're hearing of recent trends of increasing emergency mental health act assessments for new patients. And of course, there's evidence out there recently from surveys that many existing patients are skipping appointments as part of the stay at home, protect the NHS message. Individuals may have faced disrupted primary care and social supports, alongside disruption to their daily activities, routines, and of course, relationships. And I think many of my counterparts have observed that we have much to do in terms of rebuilding and signposting populations to their local community supports. I'd ask you to look out for a letter that was by the Dean of the College in the Telegraph early this week, which I think quite rightly noted that not all aspects of the current crisis can be remedied by a digital solution or even a vaccine. So it's important for us to think about demand and need moving forward. I haven't specifically want to talk about forensic pathways here in this section, but from experience, it seems to me that the greatest challenge will ripple from the wider exacerbation of social disadvantage and poverty out of this crisis. But also, I think there are positive signs that forensic providers have started to integrate management of COVID into their routine care programs. We're seeing examples, for example, of remote assessment in healthcare, but also in terms of prison care. We're seeing examples of providers within collaboratives sharing information more creatively and responsively. And also, of course, the building in of COVID into assessment tools. It goes without saying that we need to think about staff well-being, not just in terms of what we've been through, but also what we will go through. And I think staffing pressures will maintain as we start to see an evolution of track and trace. And of course, digital is a key delivery point here. I think there's a lot of excitement about the acceleration of digital solutions across mental health, but I think we also need to reflect that many of us look after groups who are digitally disadvantaged, so access can be a problem. So how do we make sure the digital solutions are the right solutions and not just the most convenient approach for providers? And we'll certainly come back to that topic today. There are some traditional approaches towards testing of risk that may need to be conducted differently, and there's no easy answer for this. But the incremental sequential approach that we take towards decreasing supervision and increasing community contacts clearly will need to be thought about in terms of local infection transmission and risk. And then, of course, many services are now thinking about rebuilding treatment models and thinking about them in terms of having to work remotely. And we can go through this in some detail, but I think there's a key point here is that many providers are now working together in new relationships, new partnerships, and a lot of these are still in their youth, they're nascent. And how do we stay true towards delivering a prevention-focused forensic model through this time? So really an awful lot to chew over, and I can't pretend that we're going to cover all this today, but I do think that we want to start conversations that will inform future discussions. And what I will do now is move on to Dr. Paul Gilluley, who I think will take this forward. Thank you, Paul.
Thank you, Kaz. Can you put my slide on before that, Megan? First slide? Yeah. Perfect. So thank you and welcome to the webinar this afternoon. I'm going to give quite a broad aspect of the COVID and the impact it's had in our services. So I'll start off by telling you a little bit about ELFT, or East London Foundation Trust. We provide mental health and also community health services for the London boroughs of Hackney, Tower Hamlets and Newham, and also for Bedfordshire and Luton, so stretching outside London as well, so quite a varied community. Both Newham and Hackney had, I think Newham was the top death rate for COVID, and Hackney the third death rate for COVID from the recent national statistics. So we've been hit quite hard by COVID. I've got some stats from today. As of today, across the services, we have 25 service users who are inpatients who are positive for COVID. At the peak, there ranged from 80 to 90 cases positive for COVID at any one time. 79 are awaiting swabs at the minute. Since the outbreak of COVID, we've had 113 deaths of service users. 20 of those are inpatient deaths, which have mainly been on the frail and elderly wards in mental health, and 93 in the community, which has been mainly the community health client group rather than the mental health client group, a couple in mental health as well. Today we have 260 staff members of 6,000 staff who are absent from work due to COVID-related absence. At the height, we had 1,000 of our staff actually absent with COVID-related absence, so quite a large proportion of staff at times, so that's been a major challenge as well. Can I have the next slide, please? So right at the start, when the NHSE made a COVID level 4 crisis, we set up our crisis room at the trust and set up a gold, silver, bronze structure underneath, command structure underneath that. Myself and the deputy chief exec took turns at being gold command, and we had held gold command meetings initially twice a day, and we're now down to 3 times a week. You'll see, I'm not going to go through these in huge details, the incident response structure. The interesting bit about that is in operational, we kept forensic separate because we knew forensic had particular there was particular issues around forensic about the secure and enclosed population and the risks inherent within that. So we had a separate silver command for that. And that used to meet initially daily and is now down to weekly. The other thing you'll notice is right at the start we put in a work stream for recovery. We planned at the start to get back to some sense of work as usual by September 2021. Can I have the next slide, please? So I'll tell you a little bit about our forensic services. So forensic services in East London have got about 260 beds. Of those 260 beds, 160 are medium secure beds on one site and 100 beds in low secure on another site about 5 miles away. During the COVID period, we've had a total of 29 positive COVID patients which have been confirmed. All occurred in medium security. Of those, 2 were actually tested positive twice with a 5-week gap in between, and actually were symptomatic on both occasions, giving us a bit of concern about whether the antibody test will help in testing your infectivity. 5 of the 29 we had to transfer to acute hospital because of respiratory distress. Of those 5, none required ventilation or transfer to intensive care, and all returned safely to medium security. So really good news for them. We've had no deaths during the COVID period, although I do understand other London medium secure units have experienced death of service users during this time. One of the major challenges we've now got is actually in low secure we had nothing. No COVID positive cases. We locked down completely. Our leave was stopped completely because I don't know if anybody's been to John Howard Centre or Wilson House, but it's right in the centre of residential areas. So actually getting out was quite difficult, particularly with the COVID being so high in those areas that we were in. So we stopped all leave completely. Restarting that leave when you've actually cohorted people for such a long time and you've got no cases is a major challenge, and that's a bit we're going through at the minute. And I'll maybe come back to that a wee bit towards the end. Can I have the next slide, please? So staff experience. Staff experience has been really, really hard. The emotional impact of working with COVID and what we've seen with COVID has been a real challenge. The inequality issues in particular in our learning disability services, where we've seen people who we'd known in the past or know now, about 27 service users with a learning disability died at this time, and only 1 had received a shielding note. So a bit of concern about where the inequalities are there for our future, and also obviously in the elderly. That's really had an impact on morale and engagement, but they've really fought through, our staff have fought through really hard. But we're now moving into, as Kaz says, into the next phase, and I'm going to concentrate a wee bit more in the next phase of what we're doing. The first phase was very much command and control. We have to close up services. We have to make sure services are as safe as possible for staff and as safe as possible for service users. But now we're on stage 2. Next slide, Megan, please. So what can we do in stage 2? Stage 2 really is learning from what we've done so far and planning on how we go forward and shaping our future as we move with that learning. So as I said, a lot of our services closed down and kind of shut down what they were actually doing to make it safer, so reduce the face-to-face. What we've done now is we've developed a work stream called Shaping Our Future. And that will use quality impact assessment tools that we've developed ourselves. And with quality assurance staff and quality improvement staff, work with directorates, including the Forensic Directorate, to look at what did you do during COVID and how did you change your service, and quality impact assess that. And from the results of that, we're hoping for discussions with staff, with service users, with carers and other stakeholders in what do we need to open up urgently? What do we need to open up, but we need to adjust it as we open it up because we're not happy with it? And this is the most important one for me, what can we ditch? What do we realise when we switched it off, we didn't need it at all? So I think that's an important bit of learning from that first spike about how can we move forward in this. And then also helping predict and plan for future scenarios. How do we continue operating while still maintaining social distances? So we've set up a work stream called Future Working. So that looks at kind of what changes do we need to make in our estates. I don't know about the medium secure units you know, but I know very few medium secure units which have nursing stations where you can have two metre distance from each other. Most of them are very, very small and compact, and when you've got several people in it, there is no chance for you distancing. So how do we manage that? How are we going to manage that is estates problem? A lot of people have also been working from home and doing things remotely. There's some of that we don't want to lose. How do we work in a new way of working that we need to develop? So plan for the scenarios in that as well. And then redesigning the future. I mean, there's been a lot of talk about you know, waiting for the mental health surge coming and everything else. I don't think we're expecting to go back to normal. We will never go back to normal. We will move into something new, and we will move on to something new. But we have to plan for that and design for that and learn for that. No presentation from East London would be complete without a picture of a driver diagram. So can I have the next slide, please? So here we have the driver diagram that gives our plan of how, through quality improvement, we're going to move forward. And it kind of captures some of those work streams I've talked about and some I haven't talked about yet. So the future of work I've spoken about already. Shaping our future, I've spoken a bit about that. If we're going to have this new workforce, we're going to have a leadership that's equipped to manage that workforce, to actually lead in the way forward. So we've got a work stream looking at leadership and how do we equip our leadership for managing the new workforce that we've got, and how we work in new ways. We're going to have some difficult conversations with people, particularly about death and about vulnerabilities, and we have to think about how do we skill our staff to be leading through this, leading through the anxieties of their teams, whilst they also have anxieties themselves. How do we support them with that? Inequalities. I have a major challenge with this, particularly with mental health. Kaz will know as well, mental health medical directors who kind of quickly react and say, yeah, we should say to our BME staff, if they don't want to work in the clinical frontline, then they shouldn't work in the clinical frontline, we should remove them. If I remove BME staff from my clinical frontline, I don't have services. I have no services at all. So that's not the answer. So we've developed a risk assessment tool which will assess vulnerabilities and then allow a structured discussion with line managers to discuss how we can actually mitigate against those risk factors. We also have to look in, as I say already, about the inequalities we've seen in learning disabilities, also in our population of elderly. And if we're going through a second spike, how do we shield against that? How do we manage that proactively from what we've learned from the first one? So there's a whole piece of work that needs done in inequalities. The last two I'm going to take together, which is co-production. And I'm actually leading in this, and this is, I've got the executive lead in this, but it's really been led by our Director of People Participation. And this is a really important, it sounds as if it's quite easy, and I never think it is. And the main job in this is defining what co-production actually is for us. And then once we've defined it, how do we make sure it's embedded in everything we do within the organisation? So firstly, it's to look at co-production from an organisational perspective and make sure all these changes we're making in the future are involving our service users, are involving our staff, are involving our carers and our other stakeholders. So really making a big investment into co-production. We also want to work actually with communities. A lot of our work, if you know our strategy, is about population health. So I don't know about you, but my experience is over the COVID pandemic, there's been huge advances in a lot of communities that they've done spontaneously to build up their community's resilience. I'll give you an example. Locally in some streets, they've developed WhatsApp groups so they're in contact with each other. So if somebody's ill, they'll get their shopping and everything else. So the community has become much more cohesive. We want to look at identifying where that's occurred in communities and how we can then go into communities and empower and enable communities to maintain that resilience and build it further. It's our view through that you actually reduce the pressure on mental health services and other health services. So we're going to go and do that. And you wonder how you would do that, but actually a huge amount of our staff are local residents. Our governors are a major source of fantastic information of what's going on locally. And we'll be using them, and our service users and carers are really useful for knowing what's going on in their communities. So we'll be using that and looking at good practice and how that can be developed and how we can monitor that. And then lastly, looking at systems and how can we co-produce with other stakeholders across systems to build systems that are actually effective going forward in the future. So we're just in this, we're at the beginning of this piece of work. We've just set up the work streams at the moment. Our co-production work stream met yesterday. We're meeting weekly at the moment as we move forward. But that's our way of moving forward in the next phase of the COVID pandemic.
Okay. Thank you, Paul. I mean, it's great to have a kind of roadmap, and I'm sure we'll come back to these issues with the other speakers, and I'll be keen to move on. But I think you're right that in terms of inequalities and risk assessment from the employee perspective, we're certainly kind of getting a generous amount to look at, but what seems key to me is that we have the right culture and approach of how these devices are used across the whole workforce, which I think is what you're saying.
Yeah.
Yeah, okay. Well, thanks, Paul. So I will now hand over to Callum Ross from Broadmoor. Hopefully Callum's there.
Can you hear me there?
We can.
Hi.
It feels like the Eurovision, Callum, but welcome.
Thank you. Yeah, I'm actually on a phone, Kaz. It's Broadmoor, being Broadmoor, I'm on a phone, but I have my video link, so apologies for any kind of strange noises. Well, thanks. And my conversation today will be largely focusing on prison and the interface, I suppose, to discuss and I suppose to look at really new ways of working between health and prison, and transferring of prisoners to hospital. So if I just move on to the next slide, please, which is really the key document. I'd urge anybody to have a look at this. It's 49 pages, and it's very, very clear. It contains within it a lot of guidance, and very usefully, it contains at the back a number of annexes which provide us all with information about the appropriate deviations from the code of practice. It also sets out much more information about the Emergency Coronavirus Act and the changes that would follow should it be enacted as well. Most importantly, I suppose, from our point of view, it contains information about the way we might work differently in a digital way. During the pandemic period, we are permitted an electronic form of communication that we never had before, and the statutory documents that we sign can be signed electronically for this period. That's going to be a useful indicator, I suppose, of how we might adapt to new technology. Presently, the regulations really do not permit electronic signatures on statutory documents, and separately, we have a group working to, I suppose, digitize the Mental Health Act. The problem that we have just now is that the reference guide is fairly clear on the matter, and it states that electronic is not sufficient for the certification of treatment or the statutory forms, and that really means that it will be very, very difficult and open to legal challenge for the CQC or for providers to come to any different position and start using electronic forms. So this will give us an opportunity, I suppose, to trial those electronic forms. Next slide. Yeah, this is a useful briefing paper. I'd urge anybody to read it. It contains a lot of information, not only about the numbers that we presently have, but also it contains a lot of information about the early and temporary discharge scheme for those prisoners nearing the end of sentences, and it also sets out all of the exclusion criteria for those individuals who are not able to be considered. And then the next slide, please. Yes, and this is a recent document. You can see there, 28th of April, providing more information about prison transfers and remissions. Both the first and the third contain numerous hyperlinks to various other documents, including in particular to a number of digital FAQs. So I'd recommend having a look at both of those and following those links. Okay, so what I'd like to talk about briefly is just have a look at some of the numbers that we are dealing with so far. So next slide, please. Okay, so prison numbers. Well, the most recent data I can put my hands on is that in prison in England and Wales, we have 404 cases as of the 12th of May. 21 prisoners and 7 members of staff have died. Now, those figures, the 404, are the confirmed figures. Going back some time back to April, it was on the 24th of April that we also had another figure declared, and that was 304 laboratory confirmed cases. But at that particular point in time, Public Health England estimated that there were 1,783 possible or probable prison cases on top of those 304. So how have we coped with the outbreak of the virus? Remarkably well, really. We haven't seen much of a change in our referral numbers. 14 referrals within the period to date, and looking back over average data, we'd expect about that as well. We'd expect about 13 there. How have we done them? Well, we have used, I suppose, the technology that we've got, but we haven't, as you can see, used any video conferences yet. We've done 11 by paper, 2 have been face-to-face, 1 by my registrar, and 1 by telephone. Now, there's a lot of talk in the papers before you that describe the concern and the necessary precautions over the governance around video links. Of the face-to-face contact, one of the remarkable things is how difficult people have found prison assessments when they have been wearing masks. And if we just go to the next slide, it is an interesting feature, I suppose, of where we are and what we are going to do as to whether or not we weigh up the benefits of video link compared to the dangers and the problems of conversing and examining individuals wearing masks. It really goes without saying that it is an impediment to communication when one is wearing a mask, and the individuals who we interview and who we might meet in prison or indeed in any other setting may infer from us a negative inference from what we are saying, because they simply cannot pick up on our emotions as well as they reasonably or previously might. And I think that's particularly important when we consider a lot of our neurodevelopmental patients as well, or individuals who struggle, I suppose, with the understanding and processing of emotions. So it's an important recognition. And my last slide, which is the slide after this, is a very simple Google image shot of transparent masks. So next slide, please. There we have what might be described as possibly the way forward, communicating with our patients with masks that allow us all to see what we are thinking by way of our mouth. Important also, I suppose, as well, to consider the deaf population in prison and in custody as we set about these kinds of interviews. So that's the story in terms of admissions to hospital. The story with regard to remissions to prison has been slightly more challenging, I suppose. Anecdotally, the prison service have experienced a greater number of remitting patients than usual. And though I don't have the precise numbers to hand, what I know is that the number of remissions has been proportionately higher than the number of transfers into hospital. So what this really means is at this present time, there is a great concentration of men who have just returned to prison and men who are awaiting a transfer to hospital and who are very unstable and unwell. At the beginning of all of this, I think the greatest fear of all was that there was going to be a problem in as much as there may have been prisons with huge number of corona patients, prisoners, and that we would face all sorts of Article 2 challenges when remitting patients from corona-free environments to a corona-heavy environment. It would seem, though, that the early predictions or the early concerns have not yet come to pass. I know that in March, the chair of the Justice Committee described prisons as being a potential hotbed for viral transmission, noting, of course, that they are overcrowded, understaffed, and often dirty. I suppose we look forward to the future with some trepidation and fear, because we must remember that the elderly population in prison is increasing at all time. Back in 2002, it was, I think, 7%. It's presently more than double that. It's now at 16%. So we have this large elderly population that will remain vulnerable. And although we can say that the numbers of corona cases and deaths in prison have been lower than predicted, I think the greatest challenge that the prison service now faces is how to reduce the restrictions that they have had to impose, the 23-hour periods of being locked in one's room, to enable, I suppose, a return to normal. And I think that's going to be the greatest challenge in the future.
Okay.
Kat, I think that probably sums up my prison part, so I'll hand over now.
Thanks, Callum. And I will just remind everyone about the ongoing webinars we got from the Prison Network that are advertised. I think the area around communication with service users is a key point, and I think a neat area just to kind of transfer across to Dr. Sarah Markham.
Hello.
Hi, Sarah.
Hi. My interest and concerns have mainly focused on protecting patients' rights within the context of the coronavirus. I mean, thankfully, the part of the Corona Act which referred to amendments to the Mental Health Act hasn't, as far as I'm aware, been activated anywhere, which is very good. I think what is of great help to patients and services and the provision of Section 17 leave during this epidemic is the guidance produced, the legal guidance revised produced by the NHS has made it very, very, very clear, wonderfully clear, how important it is where possible to patients to have their Section 17 leave, and that whether or not it's appropriate for a patient or a service to give a patient Section 17 leave should still be judged on an individual basis, and there shouldn't be blanket restrictions. Obviously, Paul has made very good case where perhaps it's not helpful to allow Section 17 leave if patients are likely to be mixing or with communities where there is a high infection rate of corona. But obviously, as we're now moving out of that lockdown period, that isn't the case. And so there should be increased emphasis on patients being allowed their Section 17 leave. I think it's, hopefully one of the long-term outcomes of the lockdown is that perhaps, the wider population will have a greater compassion and empathy for people who are in secure units, who are locked up, who don't get to socialize normally, not just during a period of pandemic, but also, for long, long periods of time when the rest of us can go out quite happily and mix and access the great outdoors whenever we wish. Could you move on to the slide, please? Thank you. It's always important to balance patients' rights. The Mental Health Act, one of its main purposes was to protect patients' rights and not merely to sanction restriction where that is appropriate. It's very important to consider the needs and indeed appropriate adjustments for people who have protected characteristics, such as people who have a neurodevelopmental disorder in the context of the pandemic. And I think recently there was a successful judicial review as regards the application of the lockdown restrictions to at least one case of a patient with autism, to whom it would have been damaging for them to have adhered strictly to the provisions of lockdown. Could you go on to the next slide, please? Digitalization, I think, has in general been welcomed by patients and carers, but of course many are still saying that it doesn't match face-to-face contact. Some therapists are also still saying it doesn't match face-to-face contact, and the nuance and the fuller forms and better communication and development and mentation of therapeutic relationships, which is still only possible in face-to-face contact. Nevertheless, it can make certain procedures more efficient, more easier to facilitate, particularly communication between patients and carers who may live or may have been detained outside of area or away from other, at distances from other important families and friends. I think it also, lends, in terms of the wider secure mental health care system, the facilitation of meetings and people being involved in meetings, especially important meetings like ethics committees. If there is that further emphasis on remote connection, you can get more important people involved in the meetings, so deliberations can be better and more informed. You can also allow more patients to access such meetings and join in such meetings as representatives, even in the context of not having Section 17 leave, if you can facilitate remote connection. So hopefully one of the things coming out of this period will be increased patient involvement in the context of the design and implementation and revision and initiation of policies and projects within services. Paul has again mentioned quite rightly the importance of embedding co-production within services. As an important adjoinder to that, I think it's important in the focus and emphasis on co-production to not forget the importance of collaboration and shared decision making within the clinician or care team patient dyad. And to ensure that patients are not just given epistemic regard at the service involvement level, but also in terms of involvement in their own care, and how important that is via whatever means, be it digital, be it face-to-face. Don't forget the very human aspects of valuing patient and carer knowledge, not just in terms of how it affects services, but how it affects and informs the care of individual patients. That's it from me.
Sarah, thank you very much. We're now going to move swiftly on to Sheena, who's going to talk about supporting carers and carer involvement. Are you there, Sheena?
I was muted.
Welcome.
Thank you. Hello everyone. Rather a strange place to begin with, but I recently watched a documentary about COVID-19. It focused on the people admitted to hospital and their families, and I was struck by the way staff were aware of how families felt and showed great compassion towards them. In one instance, a family member had turned up with a wheelchair to take his dying father home, and the staff, including a consultant, took great pains to sit him down and carefully explain why it wasn't possible. These are exceptional circumstances we're dealing with, but I couldn't help but compare this to the attitude shown to family members in secure services. It made me wonder where this obsession with confidentiality came from and why we weren't seeing families as a unit. Was it to do with the stigma connected with the old asylums and the shame of people being admitted? In general hospitals, the family is seen somehow as a unit, and there seems to be a connection straight away. So I began to think about the connections that that had been made during this time. And they were very positive. You know, at first I was very anxious that I won't be informed if my son became unwell. That's, you know, nobody's informed. When all the leave was cancelled, unlike, and I am very keen, as Sarah knows, on protecting patients' rights, but I was actually incredibly relieved that he wasn't able to go off the ward because there were already confirmed cases, and the unit's situated next to a general hospital where all cases of COVID were taken, and it's in an area in the northeast where there were many cases, and the highest number of cases. So again, there are a number of things that happened afterwards that you began to realise that things have changed, which I found to be quite revolutionary, if not revelationary. You know, change can happen in secure services, it can happen. So I wanted to look at that human impact, because you feel quite isolated as a carer about what's going on. So unable to visit services, they had to find a way of actually maintaining family relationships, which they commissioned to do, and proactively inform carers of the current situation. They've all done it differently, some being told that carers are not a priority, but then there's been an online carers forum formed in one trust, which has actually brought carers together and connected them. And they've actually connected them for the first time from different areas. So that's been a positive. In terms of the service where my son is, I've had weekly updates about what's happening on the wards, how patients and staff are protecting themselves, sort of what the ward activities are, what the photographs of the artwork that's being done on the wards. And I've heard of other carers who've been giving me updates about, you know, how the CPA is being conducted, how psychologists are being engaged on the ward, and so on. It's all been very reassuring, and I wondered why it's not been done before. It somehow feels that the services are reaching out to us at the moment and connecting us in a way that makes us feel as if we're part of that community. And that in turn actually helps us work more effectively with services. However, the most significant change has been the introduction of technology, the mobile phones and tablets on the wards. For the first time in 11 years, it feels like I'm able to have a normal relationship and conversation with my son. It seems important to remind people that he's in hospital. He has a mental illness, but so much of the time I feel as if I'm being kept away from him. So there's a Broadmoor mobile now, which he can use in his room. And I think that makes him feel more comfortable and able to chat more easily. We're having incredibly relaxed conversations that really should have happened years ago, because nobody's interrupting. There's no one hanging about waiting to use the patient phone. He's not anxious that he's holding somebody up. He's phoning me at least once a week. This is a massive shift. He rings his dad and his brother, and it's almost normalising the situation he's in. And there was a lovely moment when I'd seen this phone call on my mobile, and I didn't quite recognise it. So I phoned up, and it was the ward. And I said, oh, sorry, you know, but the guy on the other end of the phone said, oh, that's all right, I'll just go and get him. And there was none of the usual hesitation of, oh, should I be giving you information? Should I be talking to this person? It was a very natural response. Oh, I'll just go and get him. And then the second breakthrough has been, again, that connects us to the ward as well, because we chat to people more often. The second breakthrough is the ability to Skype on the ward. And, you know, I admit the first time it happened, I was taken aback by the staff in PPE. You have to talk to the staff before you're connected. And while you could feel the initial anxieties of staff, both because of their situation and the fact that they were doing something new, you recognise their vulnerabilities. You know, it's a connection we don't often feel in secure services, but it's distinctly human. You know, these are the people who are in this incredible situation looking after my son and keeping him safe. So you're actually full of admiration for what they're doing. And I think that's something that needs to be fed back to secure services, that we do value what they do. So preparing for a Skype call is a bit like preparing for a visit. I tidied the house, I put flowers in a vase, recognising that my son was actually visiting. And the words, "show me around your house, Mum," was quite overwhelming. it meant that he was able to see where I put the garden bench he'd made, where the shelves in the kitchen were, where the pottery is that holds the olive oil, and all the things we talked about that he's never been able to see before. That was another connection, a very powerful connection, because it was almost like I was welcoming him into my home again and reconnecting with what's happening in my life. So I asked myself, where is the harm in this? What is the risk in allowing this to happen on a regular basis? So really, on a simple level, the pandemic has really allowed more human connections, both with the service, both with staff. And again, another example is when you're on Skype with the staff, they wave to you. They wave and they can see my house. I'm human and I'm messy too. So, but I'm also his mum, and please notice me in future a little bit more. So I'm quite positive about the changes that have happened. And I think that they're all for the benefit and well-being of patients, carers and staff as well. So I hope they do continue. Thank you.
Thank you, Sheena. I think there was a lot in that, and I think certainly just from personal experience, some of the things that have really helped and been new across a number of providers is thinking about ethical groups and taking a holistic view about views into those groups and involving carers and spiritual figures and service users, of course. And also just a reminder that as we rebuild and start to audit and take an approach from services about what needs to improve and where the innovation has happened, to make sure that carers are fully involved in that conversation and their ideas are taken in. It seems like an obvious thing to say, but it can be easily forgotten. So thanks, Sheena.
Thank you.
I'd like to move on now to Matt Kinton.
Hi, everyone. Well, as usual, being at the end of a long list, everyone's kind of said much of what I'm going to say, so I'll be very brief. I think that this has been obviously a terrible time in all sorts of ways, but it's also been, as Sheena was just saying, it's sped up some of the ways that we were going anyway, which is, I think, to think again about ways in which we've assumed things have to be in forensic services, so that the use of IT has sped up enormously in the last couple of months, I think, which is a good thing. I've heard wonderful stories about people's relatives who live abroad being involved in contact with patients for the first time in years, because it's just never really been facilitated before, that kind of thing. We have our own remote second opinion system that I think probably goes quite well. We'll be interested to hear what everybody else thinks about it in due course. I'm a little bit more sceptical about the joy of remote tribunals. I'm not sure that that's such a great thing for patients, but let's see what people feel. One of the things that I think is really important is the role of ethics committees. We've talked about this a little bit across the Quality Network. Ethics committees, I think, have been quite an interesting experiment in some services. We've certainly heard from some services that they've sped up discharges, which is an interesting idea. I've also heard some quite interesting issues about who gets to make decisions amongst ethics committees. We had a service where the responsible clinicians were quite annoyed that the ethics committee had banned all leave. And there's a very interesting question, because actually it's the responsible clinicians who have the legal power to grant leave, not an ethics committee. An ethics committee, no more than any other management level of a hospital, can tell responsible clinicians what to do. So there was an interesting tension, but I think those tensions are useful. They made people go back to basics, talk about what was the point, what was the rationale of either allowing leave or not allowing leave. It made people think again about it from scratch, generally a good thing. Also, I heard quite some good things about risk assessments and ward rounds and so forth being shorter, snappier, of real concern about how do you get a patient's involvement with them, how do you get them to talk up to an advocate before that involvement, all those things, I think things we can take forward. I think, a last point, I think there's quite a lot of legal uncertainty at the start of this. For instance, what were the legal powers to insist upon isolation or social distancing inside a hospital, and I don't think government helped. They dithered about this, and they're still slightly dithering. I think services, however, have been almost universally very sensible about it, just knowing that there is a duty to protect patients and to do so that still upholds what human rights upholds to the degree possible all of the residual freedoms inside a forensic hospital that patients can enjoy. I think services have generally worked out that very well. I actually think that one of the reasons that it worked quite well is that there was a certain amount of legal uncertainty and nobody was just told this is how you do things. So I think we've had a great learning experience in that, and I hope it will continue. Then I'll be quiet.
Matt, can I have a follow-up question, if I may? We have a minute. And it's really, I guess, in terms of the legal guidance and alternate procedures and deviations from the Act. From the point of view of the CQC, what will be the approach to think about that as you look at services and engage with services?
Our approach is what I always try and encourage us to take anyway, which is that all we're looking for is the rationale for deviations and the cogent reason. So it's the case now that pretty much anything in the code of practice, if you have a cogent reason to do otherwise, that's okay in terms of what the courts have said. In terms of CQC, I know that sometimes inspectors might struggle to understand all of the nuances of that because, you know, it's a difficult thing and that involves a lot of value judgments. But certainly we will be looking to be supportive about how people have made arrangements. For instance, we've had a whole load of different arrangements for things like seclusion reviews, all the remote working, all the remote assessments and so forth. I've seen no problem with that because in general terms, services have been thinking very hard about how to make them effective and actually mean something, despite the fact that they're being done differently or under different timescales. That's all we really would expect of a service. I don't think we can expect anything else. Also, the NHSE guidance now is quite clear about departing from the code and is pretty useful on that, on the approaches to take.
Okay, thanks, Matt. Well, I'd like to, thank all our discussants for raising and covering quite a huge range of issues, really, and I think it will lead to more questions. So I know some of them have been answered as we've gone through. But please do continue to send us questions through the Quality Network and through the Knowledge Hub. We'll be able to share experiences through that. I think my personal reflections are that this first phase of COVID-19 has left many of us feeling, I think, somewhat fatigued, perhaps some anxious, some traumatized, and of course, some people grieving. And but I do think we will gain some further perspective about what matters to us. The focus on workforce well-being and involvement will, I'm sure, continue to hold huge value and currency moving forwards. But I think, you know, even within forensic services and beyond, we have an opportunity to make sure that we keep an eye on and limit the impact of inequalities and ensure that the wider health messages reach the populations that we care for. Thank you so much for your attention. I'd like to thank the Quality Network team for pulling this together. Please keep an eye out for future webinars, and of course, we will be around to pick up any questions beyond. But I hope you all stay healthy and see some of you soon. Bye-bye.